Somewhere in America, a phone is about to ring.
Welcome back to Shared Humanity. My name is Nelba Márquez-Greene, and in this podcast and video series, I talk to the humans behind the headlines of gun violence in a moment in history where all too often we're talking about everything but. May these survivor stories give you new perspective and empower you to hope and action. Today's episode of Shared Humanity features Megan Ranney, Dean of the School of Public Health. She is here at Yale as dean. She's an emergency room physician. She's a leading voice in firearm injury prevention and so many other issues, including the COVID-19 response. She was formerly deputy dean at Brown University at the School of Public Health there, and she is many, many other things. An extensive biography can be found online and on the Yale School of Public Health's website. And here is what is not listed. What I know about Dean Ranney is that if she's involved, there are the highest levels of academic rigor. There is good science. There is also compassion and curiosity with heavy doses of integrity. I'm honored that she's our guest today. Dean Ranney, thank you for being our guest today. Can you tell us a little bit about yourself? What brings you to the firearm injury prevention space and Yale?
Nelba, it is such a joy and a privilege to be here with you in person, here today. A little about myself. I'm an emergency physician and injury prevention researcher by training. I spent my career both working on the front lines as a practicing emergency physician and then doing the work to figure out how we can reduce the impact of violence and more particularly gun violence on our community. I started working on violence prevention long before I went into medicine or public health, and over time shifted my focus specifically to firearm injury or gun violence, partly because of the experiences that I had in the emergency department, the patients that I cared for, their families, their communities, partly because of the very clear disparities in who's exposed to violence and to gun violence in particular, but also partly because of personal experiences. You and I have had very different personal experiences with gun violence, but most of us in America have lost a friend, a family member, a colleague at this point. And I'm here at Yale as the first independent dean of our School of Public Health, because I believe that the Yale School of Public Health has the potential to create change and positive movement in our field on behalf of the health of all, in the same way that I've spent my career working to change the way that we talk about, study, and work on the epidemic of gun violence in the United States. So it's a natural extension of what I've been spending my career doing.
We are very, very lucky to have you. Now, when we say gun violence, it might look different to everyone who says it. How do you define gun violence?
So when I am talking academically, I actually usually talk about firearm injury rather than gun violence. And I do that for two reasons. The first is that I think that folks often imagine in their head two types of gun deaths. When we say the word gun violence, they think of it as urban or community violence, or they think of mass shootings.
Right.
And the reality is, as you and I both know, and as you've highlighted on this podcast before, the spectrum of firearm injury and death in our country is so much wider and deeper than just those two things. The second reason that I often talk about firearm injury rather than gun violence is because it puts it more in that injury prevention and health-based space and helps move it a little bit out of the partisan political divide and the criminal justice perspective, which, although really, really valuable, has stymied our progress on this issue over the past couple of decades.
So really important point that, well, many of them, but among them, that when firearm injury, when we talk about it here, includes all manners of death and injury, which includes people who are living with bullet-ridden bodies, families who are impacted, witnesses, people who are dealing with loss, and so many other ways our families and communities are impacted by firearm.
It's exactly right. Injury is so much broader than just the bullet hitting your body,
100%.
as horrific as that is. The emotional, mental, social, and economic injuries from firearm injury, gun violence in the United States is so much wider than just our counts of the number of patients who come to hospitals or our counts of the number of bodies that hits the doors of medical examiners and coroners across the U.S.
I'm going to, just because you went there, I'm going to switch my question order just a little bit. The Surgeon General, Vivek Murthy, just recently declared gun violence as a public health issue. And in a way that I had personally never seen before, that announcement was also released with a series of infographics that beautifully and painfully demonstrated everything that you're just saying, how everyone is touched, right? It was like a wave picture, and it said, mothers and fathers who have lost children to gun violence are XYZ, and then there was, a number next to it, and witnesses are, and it just kind of told us everything from changed behavior among regular, everyday Americans going to school, to a movie. There's not many people left in the U.S. who aren't cognizant of the danger we are in public spaces.
That's totally correct. And I give huge kudos to Surgeon General Murthy for releasing that report. It's something that many of us in the field have been working to try to make happen for a long time, and I'm really proud of and grateful for his releasing that report and also making it so accessible and understandable. But that idea of the iceberg, right, that the deaths are the tip of the iceberg, is something so important for us to understand as we have this conversation. And I think, Nelba, it informs a lot of the ways that you and I have connected in thinking about how, you, for example, get identified in terms of, very sadly, the death that you have been associated with. But people forget about that larger iceberg underneath the surface that the death represents.
Now, here at the School of Public Health, while this is your interest, you are the dean of the entire school. And one of your projects while here has been to lead us in a new strategic vision. And you are calling that strategic vision linking science and society. Tell me what that means broadly, and then we'll delve into the FIP space.
Terrific. I am so unbelievably honored to lead this school. It is a tremendous place. The staff, students, faculty, and alums are extraordinary humans who do rigorous work and are so committed to translating that work out into the world outside of academia in partnership with community to help create health. And our new vision statement, which was created collaboratively by well over 250 people across the school over the course of about 8 or 9 months, really to me serves as a emblematic statement of that work that we're committed to, that we of course want to do rigorous science and scholarship. We're committed to collecting great data, analyzing it well, developing and proving the efficacy of interventions, doing all of those important things that academic public health is supposed to do. But we are also committed to making sure that that science helps humans, because that's what we're here for. Mm-hmm. That's what makes public health in some ways different from some other disciplines. We're, of course, concerned with the mind and the science and approximating truth, but also want to make sure that the folks who we are working with and for, and sometimes on behalf of, have a say in the science that's being done and are also empowered and equipped to use the science to make their own lives healthier.
That is the broad vision for the School of Public Health as a whole. How does that translate into the firearm injury prevention work? What does that look like to you, to your colleagues, to your staff, to all of us in New Haven?
So I'll answer the question, but then I am going to ask you the same thing.
Fair.
Because you are the very first person that joined me in this work here
Fair.
at Yale and have been a big part of shaping that vision. So, if you look at my whole career, my work has always been done in collaboration with community, whether in collaboration with folks in the emergency department, with community-based organizations with whom I work, with local governments and policymakers. It's core to the way that I and most people in public health approach our work. So what we're trying to do here in our firearm injury prevention initiative at the Yale School of Public Health is an extension of that approach, starting with the voices of survivors, of communities, of healthcare workers, school teachers, family members, to inform our understanding of what injury looks like and feels like, to inform our understanding of how to think about both risk, but also importantly, resilience, right? That positive or protective factor aspect. And then to help us think about, well, if we want to do something that is going to make a difference, what might that look like? And how can we collect data to prove that we are spending our time doing things that do help real people to avoid injury, to avoid fear, to avoid depression, and more importantly, to live lives that are healthy, joyful, hopeful, and safe. And that work can span from really upstream stuff like working with community mentoring organizations. You know that I partner, for example, with 4-H nationwide, an incredible youth empowerment organization that helps proactively keep kids safe. So it can include that type of partnership upstream. It can include work kind of at the moment with folks who are at immediate risk of being shot or who have come into my emergency department after a shooting to help avert risk of future injury and to reduce the risk of downstream consequences. Or it can include work to help our communities heal, which unfortunately is perhaps the most prevalent work that we have to do right now, as you and I have talked about. We know from surveys that 54% of American adults say that either they themselves or an immediate family member has been shot or at the scene of a shooting. That percentage, of course, goes up significantly among Black and Hispanic communities, not because of any inherent risk that's caused by the amount of melanin in your skin, but because of structural and social determinants that put folks, unfortunately, in places and spaces where there are more likely to be shootings. We have to address that and help stop that cycle of fear, and I will let you talk about your vision for it in order to make progress.
I'm not certain that the change we want can happen outside relationship. And often when I have heard of other interventions or other kind of ways forward in the firearm injury prevention space, there's almost an expectation that we'll do research, we'll develop an intervention, and we can replicate it outside relationship. And I'm not sure I'm not sure change, long-term change, healthy change, equitable change, collaborative change works that way. That's why I got really excited when the whole strategic plan vibe was linking science and society, because I think that's the secret sauce. It's not that science is bad. It's not that I heard someone say the other day, well, we can't just do feel-good things. Well, I'm not suggesting we just do feel-good things, and I'm not suggesting that we do change in exclusion of science. I'm saying that without that link, it's not going to be as effective or long-term as we want it to be. We can't impose solutions on communities we're not in relationship with. We see examples of that all the time, right? So this work, this kind of focus on healthy collaboration is critical to the success of the FIP work and so many of our other initiatives. And that's why I'm so grateful it's embedded in the strategic plan.
Thank you.
Does that make sense?
It does. And I totally agree. I mean, I think it's where we in higher education need to be, that this is not just about us thinking kind of in our offices or in our classrooms, right? It is about us actually being in, to use your word, to be in relationship with the folks that we love and work and play and live with. Without that, nothing happens.
And it's in the before, right, as we're building, and it's in the dissemination of whatever research results we get or whatever we learn from our interventions or our work. How do we go back and make this kind of manageable, digestible information that can change things in communities? And I'm really excited about that.
Because why are we bothering to do this otherwise? Like, why would I bother to study this problem and to try to approximate truth around who is at risk and why, who gets protected and why, and how to mitigate all of that risk and injury? Why would I even bother to do the science if it's not in partnership? And I think one of the things that I've learned when I think about my work as an emergency physician, I'm part of a team, right? It's never just me as the doctor. That would be weird and ineffective, right? It's a doctor, a nurse, possibly a social worker, respiratory therapist, x-ray tech, of course, all the people in the lab, the folks that are cleaning the rooms, that are doing the laundry. It's also about the family members, the patient, the outside community that someone is going to go out into. And if you don't think about everyone that's part of the journey of that patient that you're caring for in the emergency department, you're going to make mistakes. And you're not going to do as good of a job of caring for the patient, diagnosing their problem, and fixing them. To me, it's the same thing with science. This is a team endeavor. And one of our goals here at the school in general, but also for this initiative, is to make sure that that team is intact, supported, and healthy so that we can make sure that our work has those effects. And it may not be me who is the one. In fact, it probably won't be, right? It's going to be the community partners. I'm going to say, related to that, Nelba, one of the things that I've always admired about you, and one of the reasons I was so excited to work with you, is because of that perspective of yours on how survivors can sit at the table in a way that's both respectful, empowering, and hope-giving, right? Because we know that one of the things that destroys hope is feeling like you don't have agency. And I wondered if you'd mind sharing some of that with the folks that are listening to this podcast.
I am happy to share. So I think that this opportunity of me being here is allowing me to draw from a well of expertise, which is different than drawing from the well of trauma, right? When survivors are called to tables to draw only exclusively from the well of trauma, it can be incredibly problematic. It can be re-traumatizing. It can be, especially when there's no exchange of, I am actually here as a community scholar, drawing from expertise, working on a research team that I am both learning from and teaching, right? And just like I learn from them, and it feels very different than other ways of engaging with survivor communities that are only beneficial, right? Because we have to talk about positionality. I work at Yale, right? I work at Yale, and like it or not, Yale is an institution. However, I am drawing from a well of my expertise and adding to the fabric of the scholarship database that exists here, right? So that is incredibly important to me. It's a different way of engaging. Every day, I was just in the parking lot outside going, had you told me 12 years ago a relationship like this was possible, I would have said no. And I'm grateful I waited. I'm grateful I waited, because this is another thing that happens in survivor communities. After time and time again of being let down, you can begin to lose that hope. You can begin to lose that sense of self-efficacy. You can begin to lose that energy of, can I make change? Can I make a difference? Right? And what this is underscoring is that together in partnership, academia and community scholars, we actually can. And not only can we, but we can do it better.
Can and must. Because gosh, if we don't, who will?
Right.
Can you share also, you and I have spent time talking about this kind of idea of the stool.
Oh, yes. I can and I will. I can and I will. And then I want to make sure for people who are listening, who the light bulb hasn't gone off on what public health actually is.
Oh.
So I want to make sure I'm going to do this. And then I want to go into how public health can impact what I'm about to say. Is that all right?
That's fine.
Is that good, right? I think that uniquely survivors sit at this intersection of grief and trauma, but also injustice in a very different way than almost any other issue in the United States. If my person dies in a car accident, that is really tragic. And also we have loss. When we lost Anna in Sandy Hook, it was almost like an OL. And we see it happening over and over and over and over again. And we have had some marginal change, but largely this nation, in my opinion, has turned a blind eye to the reasonable measures that we could be taking to make this not an everyday reality that impacts Americans between 100 and 120 a day.
Between 100 and 120 a day die, and another 300-ish are injured, which is just mind-boggling.
Mind-boggling. And we're not counting witnesses. We're not counting first responders. We're not counting teachers who are dealing, and other community members who are dealing with the aftermath, really dealing. We also tend to pay attention as long as cameras are involved, and then cameras leave. And we don't think about the families and individuals we have forced to carry this lift for the rest of their life. We have this misconception of what grief is, right? We can strong arm and white knuckle our way. I just said yesterday, I'm not white knuckling my way through December. I will not. I'm going to accept all the help. I'm going to say yes to all the offers. My friends just organized a meal train. And I just said yes, right? Because even 12 years later, and I would imagine 30 and 40 years later, my body is still going to feel this way. So we sit uniquely at this intersection of grief and injustice and trauma that doesn't go away, that actually is compounded because we haven't resolved or in any way made large enough change to make this better. So I often say that we have this two-legged stool where what's expected of survivors is this post-traumatic growth without the appropriate resources that is unrealistic. One of my pet peeves is when I go out and people go, "What are you doing now?" And I want to ask, am I being met with the appropriate level of resources for that question to be asked? I can say that now I am, but I can think of 20 people just in my inner circle who are not. And yet we still have that expectation of post-traumatic growth, that they'll get over it, that they'll turn tragedy into triumph, that they'll start a nonprofit, that they will find a way to, it's just ridiculous what we do to survivors.
And I also think that separates people, right? You and I have talked about, I don't know, I think there's real value in coming together and being in community. And I think it's one of the things that you do so beautifully is that you join with others and create spaces where people can share their experiences, potentially share their grief, but also share those pathways towards hope, that don't put it entirely on the single person.
Exactly.
But rather allow us to hold each other up.
And teach folks and uplift folks when they are noticing their issues in the system. I want survivors to feel free. If they have not been able to turn tragedy into triumph, I want them to know they've probably been failed by a system, right? I want to work with them so that they know what to ask and so that they're encouraged to ask. That light bulb moment went off for me in one of my first weeks here at Yale about a year ago when I read one of the research papers that said that in the first year, moms and siblings of folks who are lost to gun violence don't get primary care. And I thought to myself, oh my gosh, I don't know anyone in my group, right, of people that I talk to, people that I counsel, people that I work with, who knows that. I can share that information over there and say, this is something we have to make sure families understand that, yes, you are going to be less likely now to see primary care, but you need that because we don't want you to miss that mammogram. We don't want you to miss your dental visit. We don't want your child to miss their vaccination schedule, their vaccination routine. We want you to be okay. We know you're not okay, but here are some things that you can actually do. So survivors need more than this tragedy to triumph narrative or this kind of blaming for not being better. We need information.
And that's when you asked me kind of what specifics about what the public health model is, that's exactly what it provides. So when we use the public health model for firearm injury, it comes at the problem not from a blame perspective, but rather from a measurement of the problem. How common is this health problem? Injury, death, the ripple effects from a shooting. Who's at risk, who's protected, and why? Then we help to develop things that may work in partnership with community. And once we show that they work, so it's not just a feel-good exercise, we spread them out and disseminate them. Core to the public health model, and this is where public health and research will differ a little bit from activism and advocacy, right? Core to our work is that deep reliance on trying to identify facts and truth, and a commitment to sharing them back out in ways that they can then be used by others. So it may be that advocates and activists can use the data that's created by us in order to help drive change in policies or in structures or in support systems. It may be that our research in and of itself helps to set up some of those changes. But it is built on a foundation of a belief in shared facts, as well as shared stories informing action.
I didn't know that this sharing of narrative and sharing of fact and information could feel so hopeful. I didn't know that. And I'm grateful to be here to see it. But again, simply for people who are listening who are like, well, what is public health anyway? Could you break it down in digestible pieces and tell me what public health is?
Ooh. Public health is the pursuit of the conditions that allow a community or society to be healthy. When I'm working as a doctor, I'm working one-on-one with a patient. It's all about that individual relationship. When I'm working with my public health hat on, I'm thinking about what are the conditions and the systems and the structures that I need to address in order to help keep the most people healthy, physically, socially, emotionally, mentally, and economically, rather than just looking through that single patient lens. And when we do that work in public health, it sometimes is talking about things that can change on the level of the family. Sometimes it's about things we can change in a community or a neighborhood, putting in trees or improving buildings. Sometimes it's bigger, like getting rid of the lead pipes in a city and making sure that kids aren't exposed to lead, or maybe putting new policies in place to make sure that folks who buy a firearm have a safe storage device that goes along with it. And sometimes it's really big picture, thinking about how we care about each other.
Yeah.
How we create places and spaces that allow us to connect as humans.
And sometimes one of my favorite kind of pieces that I saw you in was a little over a year ago, you testified before Congress on gun violence as a public health issue. And I could only imagine the levels of preparation required for something like that and the levels of stress required for that kind of inquiry from members of Congress who were both kind of with you all the way and some who were a bit more challenging. But you gave a beautiful breakdown of why gun violence as a public health issue and the tools and the methods. Can you brief us the way you briefed Congress?
I can try. Well, gun violence is a public health issue because it is at its core a health problem. It's about injury to the body of the person who's shot and to the community around them. And the public health approach provides a different path forwards when we're talking about reducing that injury. Because it's a really standard framework that we use for every type of injury or illness in the world. 4 basic steps. The first is you gather data on how common a problem is. The next is you look at who's at greater risk than others or who might be protected, all other things being equal. The third step is you develop and evaluate interventions that could make a difference. Those interventions for gun violence could range from early childhood education through programs for kids who are in the hospital who have been in fights or have already been shot, through changes to the environment in which people live, greening of vacant lots, putting in streetlights, programs like that. In that third step of the public health approach, we don't just say, oh, this intervention might work to reduce risk or improve protection, but we also study it to prove that it makes a difference and to prove that it makes a difference for the people who are highest risk. And then the final step in the 4-step public health approach is that we scale what works, and then we go back to the beginning again and measure and keep trying to improve. And when we apply that 4-step approach, we've succeeded over and over again throughout history. We've succeeded in reducing car crash deaths, not by taking cars off the road, but by putting in place seatbelts and drunk driving laws. And heck, ride shares make a big difference in the number of car deaths. We've used the 4-step approach, of course, for HIV and AIDS. We've discovered the virus, we've figured out who's at risk, and then we've put harm reduction programs in place. Abstinence only doesn't work, so we've thought about other ways to help reduce risk of infection and of progression of HIV to AIDS and to death. We haven't really applied it systematically to firearm injury, partly because there wasn't funding from the federal government to apply that 4-step approach for so long, but partly also because very few people conceptualize of it as a health problem rather than as a political or crime problem.
Also as a problem that you get into because of your own sin, bad luck, or, right? Oftentimes we look at gun violence and we say things like wrong place, wrong time. We say things I have had said to me by elected officials. You know, if you just accepted God, right? So looking at gun violence as a public health issue, what it does is it removes the stigma, one of the things, that it has happened to you because you are bad. And think about all of the places we do that. When someone loses a person they love to suicide, I hear from those moms, and the first thing they will always say is, I didn't lose my child like you. I lost myself to suicide, so I don't feel like I even have the right to speak to you. And I say, what? We have still both lost children. To me, it is the same. Yeah. How can we connect and how can we bridge in order to help each other, right? Think about urban violence. Think about the lack of empathy we have in community violence when folks lose their loved ones in an urban center or in a rural area versus in a mass shooting, right? We have made this horrible competition of empathy and resources. And one of the things I get really excited about with the public health approach is that it roots it in something different. It roots it in science. It roots it in data. And it says, no, this is a health-based problem.
And they've done it for stuff, HIV, cancer, people. And when you take a health-based approach, you can remove that stigma. And I'll say, kudos to our folks at our School of Public Health who have done such tremendous work on destigmatizing health problems, whether it's aging, HIV, I could go on. But that is the beauty of this approach. Thank you for calling that out, Nelba.
And in the absence of good data,
then you're stuck with stigma and hopelessness.
Desperation, right? And we are not desperate because we are bad. We are desperate because we want, I would say, you would not find a person on the streets of the United States who would say, yay, gun violence, right? People want gun violence to end. But in the absence of good data, we get desperate and we say wacky things.
And I also think that in the absence of good data and the absence of data-driven solutions, people lose hope.
Yes.
And so either either they say wacky things or they just tune out because it's too overwhelming to think about. I think that's a danger for the field of pursuit of health in general right now.
Yeah.
Is the danger of kind of tuning out. And I think one of the things that we can do here with our firearm injury prevention initiative, but also more broadly at the School of Public Health, is to provide those exemplars of hope, as well as pathways for folks who are not part of our school to use those examples, to use that data for change in their own community. I think about some of the work that you and I are just starting to do because it's taken us time to get into relationship. I'm new in Connecticut, right? I need to acknowledge that. I have a long history and deep roots in Rhode Island, where I spent the past 20 years. Very proud to sit on the board of the Nonviolence Institute there, but just creating those roots here in Connecticut. And as we are creating them, as you're helping me to meet folks and to create those partnerships, we have some really exciting projects ahead in Hartford, here in New Haven, where we'll hopefully be able to support local communities in their quest to gather data and to see whether what they're doing does help the most people and in the community that they care about.
I would love to see for survivors a world where pathology or unrealistic expectations of strength are switched out for the normalization of the grief experience, mitigation of trauma, and for us to actually address the injustice in the systems that keep access to care away from survivors.
Well, and I think part of the injustice is the lack of empowerment with facts, right? It's the fact that people are isolated and don't know that there are options out there. I just gave a talk yesterday at Yale, where I talked about gun violence as a public health problem, and someone came up to me afterwards and said that they're a practicing physician and take care of a lot of folks in their clinic, but often take care of gun violence survivors because of the type of physician that they are, and said, well, I had no idea that there was more that I could do for them than just to treat the physical problem that brought them here.
Right.
And so it opened up this whole possibility of us talking about all the resources that are available here in New Haven, across the state, but also some of these virtual groups for survivors and their families that make a big difference.
And for people who support them.
Yeah.
Right? Sometimes some of the most powerful interventions is to teach the people who support those most impacted how to care for them. Do you have any questions for me?
I feel like I've been asking you questions all along.
Okay. I also got questions from a few folks on social media. If you want to.
Can I do? Why do you think this collaboration is so hard? I mean, I think when I brought you on board here, there were not a lot of examples of folks like I'm going to call it out. Folks like you and me working together.
No.
Inside the academy.
Right.
What do you think makes it so hard?
It's so interesting because at some point this week, someone said, why haven't we figured out community engagement? We should be able to find a solution, replicate it, and just do it, get it done. And it's what I think in part it's because it requires relationship, and relationships require showing up. Relationships require showing up and working through rupture and repair cycles. And oftentimes between academic institutions and, actually impacted communities, there can be very different goals and objectives, right? So sitting and working through goal setting and approach and talking about uncomfortable things like money and how we do this with ways of integrity and integrating ideas, it requires humility, it requires curiosity, it requires showing up to do the hard work. And I don't know how many people, especially now, are times are really, really hard. It's much easier to go, that is too hard. I'm just going to walk away. It requires a whole lot of courage. It requires a whole lot of strength. And again, I was just sitting in my car before getting out here going, wow, this is actually a really brilliant moment and a really sacred opportunity that no one, especially me, should be taking for granted. So that that was a good thing.
Well, I feel a sacred privilege sitting in this chair where so many others have sat with you over the last few months.
For sure. So some questions from folks who I said, hey, I'm going to be interviewing Dean Megan Ranney are, one, are there any current studies on who is shooting whom, why, and with what? Because there are so many different settings where firearm injury happens.
It's a great question. So I'll say, we're just starting to move beyond the broadest brushstrokes of saying who's shooting whom and why and with what. We do know that young Black and Hispanic boys and young men are unfortunately at disproportionate risk of both getting shot and being the perpetrator. And so often that perpetration and victimization is an intersecting cycle. We also know that middle-aged and older white men and Native American men are the most likely to die of firearm suicide, with military and veterans also being overrepresented among firearm suicide deaths. We know a little bit about geography. This happens everywhere. You don't have to live in a city or in the country, unfortunately, to get shot. And we know that most shootings in the United States happen with a handgun, most of which are semi-automatic at this point. Beyond that, we're just starting to kind of get into the granular details about who and why and how. I'll say partner violence, we know, is a leading reason why women get shot. And a leading cause of women's death in America is firearm domestic violence. But there's a lot more to do. And I'll say, though, that naming who shot is only the first step, right? Because this shouldn't just be like exhibitionist.
Right.
We name who shot so that we can figure out why and then fix it.
Another question here is, has research borne out at all? Have we done it? Are we allowed to do it? That one pathway forward is anything like with bans or restrictions?
So there's definitely some good data on the effect of policies. And for folks that are interested in this, I would say to go to the RAND website, R-A-N-D. They have a website that has a really easy to understand graph that shows, to the best of our knowledge, the effects of different kinds of policies on different kinds of firearm injury and death. Community violence, suicide, domestic violence, unintentional childhood shootings. There are some policies that are effective. I'll say things like red flag laws. Connecticut was the first state to have a red flag law long before Sandy Hook, and has expanded it in recent years. As of 2022, families, law enforcement officers, and healthcare professionals can all activate it. It requires judicial involvement. It is not an excuse for taking people's guns away forever, but it can be used very, very effectively to reduce the risk of firearm suicide. And there's some kind of preliminary data that it may also reduce the risk of mass shootings to have a good red flag law in place. Background checks make a difference. Safe storage laws make a difference. I know that you've had Kristen Song on this podcast. But with all of these policies, you can put a law in place, but there's also the culture and enforcement, right? Which is not, I'm not talking necessarily about police enforcement, but around the way that we relate to each other in community. And one of the things that we do find, and I'll highlight again 4-H here, is that when you have a community that believes in a principle of safety around firearm ownership, we find lower rates of firearm injury and death associated. So policies are part of the solution, but there's a lot of other stuff that has to go into it as well.
For sure. You brought up a website with information. One of the things that is just kind of eroding the ecosystem in firearm injury prevention is misinformation. And how do we know when something is good data? How do I know where to look? Not me, Nelba, but I'm out there. I have another job. I'm raising 3 kids. I don't have a ton of time. I've got about a 30-minute window of scrolling, and I mostly go on TikTok before bed to kind of relax. How do I get good information? How do I separate fact from stuff that's not true but really popular?
Fiction or worse. Yeah. So our Yale School of Public Health social media account is, I think, pretty extraordinary and very committed to sharing facts that are based off of good research.
Okay.
You and I are working on our website for our firearm injury prevention initiative. There's others too. For example, your local epidemiologist, run by Caitlin Jettalina, is a great site.
Who we've had here at Yale.
Yep. There's the Unbiased Science Pod. YouTube Health actually has a little check mark for credentialed health communicators as well. So I would start with the ones that I've listed and then go from there. Sometimes when something sounds too good to be true, it often is. And so I do think having a little skepticism is worthwhile. But we're trying here to make sure that we are sharing those facts and truths and also the nuances about what we do and don't know. And
I think you're going to like this one. What keeps you hopeful in the current environment we're in this space?
Nelba, you keep me hopeful. That's part of it. Sure. But it's also the work of so many people around the country. So we're doing this podcast on a Thursday. This weekend, I'm going to Seattle. I'm sorry you're not going to be able to join me there, but next year, for our third ever convening of our Research Society for the Prevention of Firearm-Related Harms. This started out of work that I and about a dozen of us have been doing for 15 plus years. It used to be that we could literally sit in a room and count on two hands the number of people that were there, trying to think about how do we bring both facts and stories to bear on addressing this problem. Next week in Seattle, we're going to have 800 people, survivors, researchers, social workers, nurses, physicians, all together committed to joining facts and stories to inform action. And that gives me hope. I mean, that's a tremendous group that we have activated across the country to do this work in ways that are based on truth rather than on falsehoods. And I'll highlight that group is a really ideologically as well as geographically diverse group, that it's not all Northeasterners or people who look one way or another or who have one lived experience or another. And the third thing that gives me hope is that there are real examples across this country of places that have made a dent in the number of firearm injuries and deaths and in the way that they are supporting the survivor community. Here in New Haven, there's the Garden of Remembrance, which I know you've talked to the moms about. That's gorgeous and is something that gives me hope.
And in partnership with the School of the Environment here at Yale, right? It's another example of what can happen when we link science and society. It's a beautiful one, actually. Yeah. The town is doing some extraordinary things, and hopefully we will get to work with them in the execution of some of those extraordinary things.
And there are a bunch of groups here in Connecticut, and I won't start to name them because then I'll unintentionally
leave one out and then I'll feel bad.
Yeah. But there are a lot of groups across Connecticut. There are 18 different groups that the Department of Public Health has helped fund that are doing the work to help support communities here to reduce every type of firearm injury and death. And again, back in Rhode Island, where I spent the last 20 years, there are some groups doing extraordinary stuff. So I do see a lot of examples of hope. The question to me is, how do we scale them more effectively? And that takes all of us in our own communities. That's not my job. I'm not a politician. But I can help to create resources and playbooks that can be available to all.
And we can shine light on some of that extraordinary work. We can help platform some of that extraordinary work. I was going
to say, can I ask you that question, Nelba? What gives you hope?
I was going to say, another thing that gives me hope is watching specifically Black and brown researchers say, we have had enough of being investigated. We are going to take back and lead some of the extraordinary research that is changing the outcomes for folks who live in communities that are most deeply impacted by community violence. That's another thing. And I, when I came to Yale, I started reading and I was like, oh my gosh, there are people doing the work in that way too. I think I find hope also in having other ways of measuring success that's not just in the FIP space. And that goes along with self-care. I find if I'm not taking care of myself, it is more difficult for me to be hopeful. So I am here and I am grateful. I also like to take pictures of birds. And I love music. I have seen Wicked twice. I will probably go again in the next few days. I love music. I like to go to concerts. I try to anchor the hope in making sure that my cup is full and not just in the product of the work. And also I find hope in showing up to tables that matter and are doing extraordinary things. And also in watching people get curious and want to show up to those tables too, even if they're not in my place in the ecosystem of firearm injury prevention, but that Yale is taking this chance, that other academic institutions, that community groups, that advocacy spaces. Just recently I had this, small rupture with a advocacy group, right? And I said to them, this was shitty. It was really shitty. And their response wasn't go away. Their response was, can we talk about it? That gave me hope, right? We're starting to have and privilege important, maybe difficult, but important conversations that can lead to a different place. Maybe we're not going to agree on everything all the time. I've got really concrete ideas on how I think things should be, but perhaps we can at least coexist in the same space, respecting each other's places. Just
100%. And I actually think that if we agree with each other all the time, we're missing some stuff.
Something's wrong. Yeah.
Something's wrong.
Yeah.
That means that there's unspoken, there are things that are unspoken. And I think it's really important for us to be in dialogue and conversation with people with whom we think we may disagree.
Yeah.
That's the only
Not the easiest.
way forward.
Not the easiest, but yes, certainly a pathway forward.
As we get close to the end of this, Nelba, I do want to recognize that we're coming up on an anniversary.
Yep.
An anniversary that's difficult for you. 12 years.
Yeah.
And I think there's probably nobody listening to this podcast who doesn't remember that day.
Right.
But most of all, you.
Right.
And I want to recognize your strength in being here today and engaging with me in this conversation in a month that is so difficult. And as I've gotten to know you over the last decade, one of the things that I think gives you strength and self-care is the way in which you honor Anna Grace and hold her with you and have her be present for all of us that know you, even if we didn't know her.
Right.
How do you do that? How do you honor her?
So I'll answer that question by saying that this is another thing that anchors me in the work. What ties me to other families who have also lost loved ones to gun violence is not the activism or the change we want to see, is that I can imagine that these people love their person as much as I loved Anna. Mm-hmm. That's the anchor for me. So when I sit in a room with survivors, I remember the names. I hear and see the stories, whether it's a sibling or a spouse or a child or a grandparent. I put myself in the place of these are people who lost their person, who was loved as much as mine. So it doesn't matter to me if it was a suicide or if it was in a rural community or if it was in a community or if it was a police shooting or if it was a mass shooting. I am not thinking about the circumstance. I am not thinking about who was in the wrong place or were they a part of something or not. I am thinking, oh, they love their person as much as I love mine. And Anna was an incredibly well-loved child. And the world is a much less bright place without her in it. And that is how I view everyone who sits in that chair and all the survivors I get to meet. So part of how I remember her is, through our work, through our charity, all of the good things we do. And part of that is by making sure Isaiah, Jimmy, and I live our most thriving lives. right? That we are as healthy and well. And again, that comes from a strong place of faith. That comes from being incredibly gracious to ourselves first in those weeks that are difficult. And if I couldn't come here, I know I would have been able to call you and say, I can't do this. And I know that you trusted me enough to say that to you. And that's the only reason you showed up, because you trusted me enough to tell you if this wasn't going to work. And actually, this is something I really, really wanted to do. I know that when we release this on the week of the anniversary, people were going to be paying attention. And what a better way to draw attention to the tools of public health than this moment, right? We want to do two things. We want to intervene before gun violence happens, and then we want to support people who have to live with this for the rest of their lives. And what a better way than public health, and what a better time than now. It doesn't, that the grief that I carry won't change, but perhaps for more of those families, it can change in the future for them with this work we do here and all the other people, those 800 people at the conference you're going to in Washington, all of the other folks at the School of Public Health and at Yale broadly, right? Because we want gun violence prevention to not just be at the School of Public Health, but at the law school, at the School of the Environment, at the School of Music, at the School of all those other places. We are all a part of the ecosystem. And I just hope that anyone in the sound of my voice that's listening to this says, yes, I want to be a part of the ecosystem. I want to be a part of this somehow with my skills, with my talent, with my whatever. I'm going to get good information. Maybe that's the one thing they change. They're going to get better information. They're going to go to RAND and they're going to get better information.
And to our website.
And to our website, which I'm sorry, we're going to put it up because I never remember the website, but we're going to put it up so that you can follow us. And again, huge credit to Dean Ranney, Dean of the School of the Yale, the first independent Dean of the School of Public Health here. And we're just excited to have her. And you should sign up on the Yale site for like blurbs. You can hear her talk about all kinds of stuff. I'm in the FIP, but she talks about all kinds of stuff. It's all super interesting. And I've got great colleagues who are doing extraordinary work also with us in FIP and more broadly. Thanks so much for listening, everyone. Thank you for listening. Shared Humanity is produced by the Yale School of Public Health. Follow us on social media at Yale SPH and learn more at sph.yale.edu/sharedhumanity. Thank you to the Yale Porvu Center and Yale Broadcast Studio for their support. If you would like to be a part of what we are growing here at the Yale School of Public Health in the Firearm Injury Prevention Initiative, please join our mailing list at fip.ysph@yale.edu.
Somewhere in America, a phone is about to ring. Somewhere